Hi, my name is Matt Rosenberg. I am a family physician in Jackson, Michigan. I've been practicing in family practice at Mid-Michigan Health Centers for about 30 years after initially starting my career in urology. If we look at the definition from the International Continence Society, the ICS, we see that OAB consists of urinary urgency with or without incontinence, often accompanied by frequency and nocturia. Urgency itself is a sudden desire to urinate. Frequency is typically defined as 8 or more voids during waking hours. Nocturia is defined as interruptions of sleep or one or more times that are due to the need to void. Now, urge urinary incontinence is involuntary leakage. However, I don't think the ICS definition tells the full story. The manifestation of overactive bladder is really the bother associated with it, specifically when OAB starts to affect the activities of daily living. Importantly, although the prevalence is consistent with OAB between men and women, as they get older, symptoms seem to differ. And personally, I see urinary incontinence more in women and frequency more in males. Since I'm in primary care, I'll speak about what we do in our office. First, I look at a patient's medical history to determine whether something may be contributing to the patient's symptoms. The typical patient will say to me, I've had this for about a year and it's getting worse. I mean, again, there's a very typical example. If the patient, for example, has poorly controlled diabetes, this may be contributing to their symptoms. And in this case, treating the diabetes is more beneficial than treating the OAB, at least initially. This is why the medical history is so important. I also want to know if they've had recent neurologic symptoms. And lastly, I'm looking at the medication history. I think you can confidently make a diagnosis of overactive bladder without diagnostic testing in the uncomplicated patient. People are embarrassed and don't want to talk about it. The difficulty I see for both men and women is getting over this embarrassment. I try to open that door early on. I think that helps, especially as they get older. It's important to understand how OAB can affect patients. In a national sample of 1,030 women aged 50 to 80, approximately 50% reported urinary incontinence in the past year. 41% described their leakage as either a major problem or somewhat of a problem, and 1 in 3 women had leakage episodes almost daily. Apart from this study, some data tells us that patients with OAB also report social isolation, loss of self-esteem, embarrassment, loss of independence, loss of dignity, anxiety, and depression. I believe overactive bladder care belongs in the primary care office because our patients trust us. In my opinion, it's easier to have a conversation about overactive bladder with patients in primary care because we have a history with them. I'll ask them questions to better understand the hidden problem and disarm any uncomfort or discomfort that they have around OAB. I think asking the right question is essential for patients to open up about their symptoms. I'll give you an example. I once noticed a patient was using pads for leakage symptoms during an office visit, and I asked her why she had not told me about this, and her response was, "You never asked me." I also believe that the treatment follow-up is very important for the patient, and I typically follow up with them after a few weeks to see if the treatment is working.